Welcome to The Explainer. Today, we're diving into the many clinical faces of Alzheimer's disease. And look, if you're a trainee, this isn't just theory. This is stuff that's becoming absolutely critical to your day-to-day practice, more so now than ever. Right, so we all learned the classic memory loss line in med school, but what does Alzheimer's really look like when a patient is sitting in front of you? The reality is it's way more complex than the textbooks let on. So let's get past that simple stereotype and dig into how this disease can actually show up in your clinic. Okay, first things first. You've got to think of Alzheimer's less like a switch that flips and more like a long, slow-burning fuse. It's a continuum. The disease is actually brewing under the surface for years, sometimes decades, before anyone notices something is wrong. So that fuse starts in what we call the preclinical phase. The pathology, the amyloid plaques, and tau tangles are building up, but the person is totally asymptomatic. Then it moves into mild cognitive impairment, or MCI. This is where you start to see some cracks in their cognition, but they're still managing their daily life. And then finally, that progresses to full-blown dementia, where their ability to function independently is really compromised. And here's why understanding this continuum is a game changer right now. This isn't just academic anymore. With new therapies like lecanemab and donanemab getting approved, catching this disease early is everything. It's no longer about just giving a name to the problem. It's about getting patients on treatments that can actually change the course of their disease. The stakes are just so much higher. All right, so let's get into the nitty-gritty. Let's talk about the cardinal symptom, memory loss. But, and this is a big but, it's a very specific kind of memory loss and one that's easy to get wrong. The technical term for this is anterograde episodic amnesia. What does that actually mean? Well, think of the brain's memory-making machinery, the part that takes today's experiences and files them away for later. In Alzheimer's, that machine is broken. It's not just about forgetting things. It's about the profound inability to form new memories of events. And this is such a key distinction you need to make in the clinic. The part of the brain that's hit early, the hippocampus, is responsible for recent memory. So your patient literally cannot remember what they ate for breakfast this morning. But what's fascinating is that other memory systems are often spared early on. They can still hold a phone number in their head for a few seconds, that's immediate memory, and they can tell you vivid stories from their childhood, that's remote memory. It's a very specific deficit. Now, here's a huge clinical pitfall, something you absolutely have to watch out for. Your patient might tell you their memory is just fine. This isn't denial. It's a neurological symptom called anosognosia, a genuine lack of awareness of their own deficits. That's why you can't rely solely on the patient's report. Getting a history from an informant, a spouse, a child, a caregiver is not optional. It is essential. But listen, Alzheimer's is so much more than just memory loss. One of the other big domains that gets hit, often pretty early, is executive function. Think of this as the CEO of the brain. So what does this look like in real life? It's the patient who suddenly can't manage their own finances, gets overwhelmed trying to plan a trip, or just can't multitask anymore. These complex step-by-step tasks just fall apart. Okay, moving on from the purely cognitive stuff, let's talk about something else, the behavioral and psychological symptoms. And honestly, this is often the part of the disease that's most distressing for families and caregivers. You're going to see a whole range of these neuropsychiatric symptoms. A big one is apathy, just a total loss of motivation and interest. It can look a lot like depression, but it's actually a core feature of the disease itself. Then you can get irritability, agitation, even psychosis with delusions. It's a huge spectrum. Here's another really important clinical pearl. Motor symptoms, things like Parkinsonism, myoclonus, seizures, they are not early features of typical Alzheimer's. If you see those things cropping up early in someone with cognitive decline, alarm bells should be going off. That's a huge red flag telling you to think about other diagnoses. All right, now let's talk about the imposters, the times when Alzheimer's doesn't look like Alzheimer's at all. These are the atypical presentations, and they can really throw you for a loop, especially because they often show up in younger patients, say under 65. So first up is a fascinating one called posterior cortical atrophy, or PCA. The classic story here is a patient who goes to their eye doctor over and over, complaining they can't see properly. But every eye exam comes back perfectly normal. Why? Because the problem isn't their eyes. It's their brain's visual processing centers in the back of the head that are failing. So what does this actually look like for the patient? They might look at a busy picture and only be able to see one object at a time. That's simultaneous nausea.
Or they'll try to grab a cup of coffee and keep missing it. That's optic ataxia. They struggle to read or navigate. And the key thing is, all of this can happen before their memory starts to go.
Another one of these atypical forms is the logopenic variant of primary progressive aphasia, or PPA. Now, PPA is a language disorder, but what's important here is that this specific type of PPA is almost always caused by underlying Alzheimer's disease. So, what will you hear? The most striking feature is this constant, frustrating search for words. Their speech is full of long pauses and filler words as they're hunting for the right noun. They'll have trouble naming things. But what's interesting is that their grammar is usually pretty good, and they can still understand what you're saying, at least in the early stages. Okay, so we've seen all these different ways Alzheimer's can present. How on earth do we put all the pieces together and actually make a diagnosis? Well, the modern approach combines that good old-fashioned clinical exam with some really powerful biomarkers.
Your detailed history is still king, of course, but a brain MRI is absolutely standard practice. It does two key things for us. One, it helps us rule out other culprits, like a stroke or a tumor. And two, it can actually show us the classic signature of Alzheimer's, that specific pattern of atrophy, especially in the medial temporal lobes. And this is where things get really cool. We now have this biological framework called ATN. It's a way to define the disease not just by symptoms, but by the actual pathology in the brain. A stands for amyloid. We can measure that with a spinal tap or a PET scan. T stands for tau, which we can also measure. And N is for neurodegeneration, which we can see on an MRI. It gives us incredible diagnostic confidence. Okay, let's wrap this up. What is the big takeaway here? Why does all of this matter? For you, right now, in your clinic. Look, being able to spot these different presentations, the classic memory loss, the visual PCA variant, the language-based PPA, it's not just a neat party trick for neurologists anymore. It's absolutely essential. Because a timely, accurate diagnosis is the gateway to getting patients access to these new therapies that can actually slow the disease down. It's a mandate for action. So I'll leave you with this question to think about. Are you ready to spot Alzheimer's in all its disguises? Because ultimately, that's the big takeaway. Learning to see beyond just memory loss and recognizing these other patterns is how you're going to fundamentally change things for your patients. This is a core competency for every clinician practicing today.